Grounded in research, individually focused, and back at last. Welcome to the Thriving with Stripes podcast.
Hello, welcome back to Thriving with Stripes. This is episode 4. My name's Tom Stott, sitting along Dr. Patty Stott. Hi, Dr. Patty.
Good morning.
And we are talking today tethered cord syndrome in EDS, in the field of hypermobility.
In the field of connective tissue disorders, I think is probably the right
better way to
terminology.
frame it.
Mm-hmm.
And some non-surgical things.
Lots of non-surgical things. Yeah.
So breaking down tether cord, literally, probably a good place to start. Kind of talk me through what you see, how you describe it, some common misnomers. You want to paint the landscape for tether cord first?
And my background within the clinic, this is kind of, it's become my specialty, into my own personal story as well, just from the idea of understanding that things don't just randomly land on you from outer space. Like even with genetic diagnoses, things get flared up and things happen because of other things that are happening to us. So that's where, in my own personal story, and then with my patients as well, and wondering, why did we end up here? Why now are we seeing these things happen when, and there might have been some clues before, right? And that's what I want to talk about is one thing to get straight. I am not anti-surgery, and I always tell my patients this. I think it's extremely important to be followed by a knowledgeable neurosurgeon or neurologist that understands the complexity of what's happening. I'm all for the appropriate timing of surgery, or if we can get people into remission, considering holding off, or how do we have the best outcomes knowing the science behind it. So I want to say that first. I have some people that just on the timeline that we're on, the level of symptoms that they have, or the accessibility to care where they are, the option is surgery. And then we work on all of the other things to try to reduce the risk of retethering or more damage to neural tissue, or more inflammation, I should say, not necessarily damage, but we can have a lot of neurological irritation. So I just wanted to get that out of the way first, because It's something I like to tell my patients too. I'll talk surgery with you. I'll talk about who to see and when to see. I'd love to have you monitored. And you have to understand the science behind all of it. So we're going to talk about the science today of what tethered cord is in this population, like what it really is from that cellular level, and what's happening in the neurological tissue, and why we can actually put so many people into remission. It just takes a long time, to be honest.
Sure. All right. Yeah. So where do you want to start then?
Let's start with what tethered cord is, right? So tethered cord in the general population, tethered cord syndrome, is this idea that the cord is actually, as the cord comes down, we have something called the conus, which is kind of where it looks like a little cone, where the meat of the spinal cord looks like it ends in our MRIs and imaging, things like that. There's still tissue around there in the phylum that attaches down lower. But the conus itself is actually riding low. So it's actually being pulled down and anchored down closer to our tailbone. So you get this pulling sensation through the neurological system. So I feel like that's what we do with a lot of EDS stuff. Like it kind of looks like this, but it's not really that, but it kind of looks like it. So like some of the symptoms do match up for sure. So tethering in the general population is this anatomical shift of position in a vertical direction. So you have this pulling downward. And what happens in the tethered cord or the EDS population with cord tethering, and I always try to watch my language because it is a little bit different than general tethered cord, or sometimes we call it occult tethered cord, or I like to use cord tethering, or neurological irritation throughout the entire system is really what's happening. Or diseased phylum is another one, because that's something that does happen as well. So what happens with this population is we have some sort of neuroinflammatory response around the neurological tissue of the phylum, and typically for most people throughout the entire body. And I don't know if we want to go really far down this rabbit hole today, how much time we want to talk about the details of like how we get there, what the moving parts are, because this is complex. I know that providers would like to simplify this in, okay, give me the diagnosis, now how do we treat this? And actually the important piece is, okay, if we think you have what matches the diagnosis, how did we get here? And then how do we work you out of those things that got you here?
Sure. And it's important, I think, to frame that it's not like you need to know a why, but you need to understand a little bit more of that process to see how to, I think of your Rubik's Cube analogy, how to undo the Rubik's Cube to pull things out of it.
Right.
And I feel like your just way that you're even using language very intentionally around the diagnosis and how to frame just talking about tethering in general, I feel like that probably comes from how some of our patients come into the office and they've just been like nudged the diagnosis by a provider, and they're like, I showed 1 or 2 symptoms and they gave me this diagnosis, and they're super scared. So you're like trying to kind of pull things back, and it might not be fully this, but it's approximating it and we can work on it.
Yeah, it is on a spectrum. Let me say that it's absolutely on a spectrum as to what this can look like for an individual, kind of like, vascular compressions or malls, and it's on a spectrum. And I think that, yes, if somebody gets to a certain point, that's where we do need to be monitored and watched, and really be, I'll almost use the words, more aggressive towards treatment, but not necessarily surgically, just like throwing everything that we have at the individual. But yeah, as providers, we have to be really careful with our words. And I think that I really do appreciate that there are providers that are recognizing that individuals that are coming in have what appear to be a crossover of tethered cord, things going down into the legs, heaviness in the legs, the weakness that people feel, or like it's almost like having a stocking type of like distribution of, I'm not getting any blood down there. There's a lot of things, urinary bowel issues, a lot of things that go into it, change in reflexes. I appreciate that people in the clinic are trying to recognize this for their patients. But if you do not follow it up with education on, wait, hold on, let me tell you what's happening in your body though, and then let's see if we can work out of it, it is extremely inflammatory to that patient. It feeds into the catastrophizing of, oh my gosh, I have tethered cord. I have to, well, if you fit into the neurological, and I argue neurovascular phenotype that we're seeing, this is what I tell my patients: listen to the calmness of my voice. You probably have a lot of things, because let's go back to what tethered cord is. But what we're finding with the neurological phenotype is that these patients have multiple systemic issues, mast cell issues, GI issues, like all of the things. And then they also have all the neurological things. So Chiari malformation, upper cervical instability, tethered cord, they kind of have all the things. So what is going on? So it's happening in occult tethered cord in those with hypermobile EDS. And they did tissue biopsies, and they found that there's an abnormal count of glial cells, mast cells, and leukocytes. So this is a neuroimmune response that's happening. If you're starting to read some of the other literature that's more in the connective tissue disorder field of talking about extracellular matrix dysfunction, and yes, hypermobile EDS and spontaneous CSF leaks because of blood-brain barrier breakdown, because that is connective tissue, neurological tissue.
Sure.
So this is very complicated, but we can break it down to the idea that neurological tissue can also be affected in an individual with connective tissue disorders. It just depends on the person. Not everybody is going to get this. In fact, when you look at when they did the phenotyping, the neurological phenotype, I think it was like 11% of the people with hypermobile EDS. That's actually the majority of my clinic. Somehow these people find me. So it's biased in my eyes. I'm like, everybody seems to have it. But what actually happens is that when you become a specialist, it's the people that haven't been helped is the ones that find you. And that's where, if we understand that this is a neuroimmune response at the level of the tissue, and you can start to see some of the other research that's coming out that's saying, hey, this is actually, we think it's like how the connective tissue is interacting with the environment too. And like, well, it's mast cells and it's these genetic collagen components too, right? Like they talk to each other or they influence each other. So people are realizing that this is extremely dynamic, how the connective tissue is supposed to be interacting with environment and inflammatory control. And those with connective tissue disorders, and this was our second podcast, right?
Mm-hmm.
On the extracellular matrix dysfunction. People with extracellular matrix dysfunction, whether it is structural, like a collagen component, or it's more functional, like we have the transforming growth factor, or even kallikrein components, it can affect how the extracellular matrix is functioning. And this includes the interstitial space. And this space, I do think, is going to be extremely important for understanding what's happening in the neurovascular structures, like tethered cord, Chiari malformation, lingering post-concussive syndromes, the things that we're having with intracranial pressure issues in people. This is all the idea that people have difficulty, and I'm not going to go into, I think we went into a little bit more detail in that one. So just to say that people that with connective tissue problems, extracellular matrix dysfunction, whether it's structural or functional, have difficulty regulating and managing inflammatory processes in the body. And if that builds up to a certain point, your lymphatic pumps shut down and you end up with something called interstitial stasis. And this can happen in between any tissues. There's actually a lot in medical science that we don't know. I know a lot of people think we know everything about the human body. I think we know less than is actually out there and available.
Sure.
Like we're catching up, but it's slowly. So for a while we've been like, oh, this in-between space, it's just space in the body. And it's not. It's actually where cytokines are released and they're supposed to be moving and things are dynamic, and it's supposed to be dynamic, and it can become static. And when it becomes static, you're not moving things through. And then you have this chronic cycle of inflammation, this self-perpetuating inflammatory cycle, because your plumbing system has stopped working. And I truly believe this is what's happening if you understand how, when it breaks through the blood-brain barrier and we get neurological tissue inflammation in some individuals, it's not limited to just the brain. It's all spinal tissue as well. And that's, again, maybe another rabbit hole we'll talk about, is like the specific collagens that are related to the meningeal tissues and things like that. Like, why are certain people ending up with this tethered cord presentation? Might be in their genetics and their environment.
Sure. Let's come back to that a little bit later. So kind of what I'm hearing is we should probably kind of historically, the way we've looked at parts of the body and disease processes have been a little bit siloed and reductionist in terms of like a liver, a stomach. And now we're starting to connect like how they talk to each other and work with each other. I think we're slowly catching on. The next big wave of science will be this like systems science of how everything communicates and works together. And that the space is probably, it reminds, as an former astronomy teacher, I think I've told you this before, you think about like space and you're like star, 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 star. And it's the stuff in between, that empty space, that there actually is some dark matter, dark energy. There's some force there. We just can't see it.
Yeah.
And I feel like a lot of this connection between the systems is going to happen in this interstitial space that you mentioned. So from a provider standpoint, it's important to frame, hey, I might see some symptoms of cord tethering perhaps, and I know this person has a connective tissue issue, and there's probably some inflammatory pathways. It's probably a better way to frame a conversation with them.
Absolutely. And there, the how somebody got there is how we treat them. And that's where you can pause and say, like, yes, this is a change in the neurological tissue. And when the plumbing shuts down, that's where you end up with the stickiness in around the tissue, around the dura, around the arachnoid layers. It's just sticky because it's this chronic inflammatory process. For those interested, you can look up what they used to call glial scars out there. And it's very similar to what's happening in this presentation as well, with just this chronic irritation and this pain sensory area that's happening, just constant inflammation that's around that neurological tissue. While the scar itself, that what feels like that tethering piece, is trying to actually protect the neurological tissue. But we have to help the inflammation to break the cycle. And this is where I say, look, this might not be on your timeline, because when we're talking about inflammation, which I'd like to pause about, because I think this is important so that providers can start to hear this, and patients too, because a lot of patients will probably go, oh yeah, that is my story. Typically there is like an algebra equation as to how somebody ends up with this cord tethering when you have a connective tissue pathology, and it is an inflammatory process. And I tend to see a combination from my individuals. And again, I explain this to patients too, because this is where I say, now we can go back and we can start to siphon that bucket. We can start to empty out what had made that bucket overflow over time. But what I typically see is this, and I know I always wag my finger at it, this inflammatory process that comes with connective tissue exposure to toxins and viruses and, plastics, pesticides, parasites, like all of these things that somebody can be exposed to. And yes, the really not great ones that we talk about are viruses and mold, but that's not everybody's story. That's what, like, you can't simplify this, but you have to know all of the things, and then we can figure out how to work with somebody. So working on the inflammatory piece is really important. As part of the inflammatory piece that I want to extract, to highlight, that I typically see with individuals is the idea of this, whether it's physical stress or trauma or emotional stress and trauma. I usually see both in somebody's story. So we're still talking, it's still the same inflammatory pool. But within that, I see people who typically have either a significant trauma or something that shifts in their support structure, like, a big change at work or a relationship that has ended or whatever it might be around that time frame as well. So you kind of have your safety netting pulled somehow. So I see the emotional, whether it's chronic in some people, but sometimes there's an acute part of it as well. So you have your safety net taken away for the neuroinflammatory control, that vagus control, the, coordinating central and peripheral nervous system, and just the conductivity. Yes, you have inflammation that's probably building up that needs to be worked on. But it's going to be the combination for a lot of people. And sometimes I do see this trail that somebody leaves behind, like the breadcrumbs of autonomic dysregulation that really needed support from a younger age that they might not have gotten. And that's not to, like, point fingers and blame anybody, because we just don't know when somebody's younger, right? So it is more of a bread trail crumb where we can start to see some glitches in the nervous system for an individual crying for help, crying for help, crying for help. And then, poop hits the fan one day. And sometimes there is, like I said, a physical stress or trauma, a stress injury, a traction injury. And that's why I don't want it to seem like I'm just saying, oh, well, there's no physical component to this. No, that's the thorn in the tiger's paw as well. This is so complicated, guys, and I'm trying to simplify it, but I want providers to know it's not going to be, oh, it's these three things for everybody. It's not, because when we talk about the physical component, the thorn in the tiger's paw, I had somebody the other day who has their spinal part, because there's usually some spinal something happening, whether it is upper cervical instability or they do have instability lower down or something's happening at their sacrum. I had somebody the other day where their stuck segment was in their thoracic spine. So it's not necessarily exactly where we think it's going to be, but there usually is something in their body that's like the hot spot that's driving kind of that nociceptive pain that turns into more of the nociplastic pain over time. So I don't want to forget that they actually have a physical body too. It's not just all inflammation. We don't want to leave anything behind. So it's this combination of this emotional stress, trauma, altered autonomic nervous system regulation, chronic inflammatory loads that might have had a very acute, like big response recently, virus or something like that. And then we can't forget the anatomy that we have to look at throughout the body.
I think it is. I mean, this is why we're talking about it. It's incredibly complicated, and
So
you want to
complicated.
give people an algorithm to follow or some type of framework. And that looks like a upside down tree of life, like roots and things connected everywhere. But it sounds like, from what you're talking about up front, the anatomy to consider, sure, like the physical
Absolutely,
body,
sure.
absolutely. We have some emotional, like trauma, stress trauma, like psychological, like any of in that wheelhouse, inflammatory markers, and autonomic nervous system dysregulation.
Mhm.
Is that pretty fair? Like, as like four things to kind of put a box around, like, can I check these 4 things and start a conversation there?
Absolutely. But not everybody's going to fit into that box. I want to be very clear. You're right. It's very, I think we try to be so reductionistic. Luckily my brain doesn't work that way. My brain is always like branching off and thinking of other things. So, the least reductionistic you can be and consider that somebody might be dealing with all of the things, I think is the most helpful part of it. And you don't want to overtreat somebody, right? Like you're not working on necessarily all these things at once. But if we're talking about treatment and treatment strategies, like what do we do in the clinic? And, you've worked with some tethered cord people now too, and you've gotten to see, um, just in some unexpected ways of working with an individual that is through telehealth, and they can see relief in working through those other components. So what I typically do work on, and um, I'm a little spoiled in my profession because I do work on the functional and foundational medicine piece. I do talk about viruses. I do talk about mold. I do talk about those things. So when I'm talking to somebody or like working on them, we're having those conversations in tandem. So a little spoiled in my own practice, but working on the inflammatory piece, whether it's the superficial, and we'll talk about mast cells soon. Um, but there's a reason why mast cells are agitated. Still another thing that doesn't just drop on you from outer space. You can have a predisposition through a connective tissue pathology to have abnormal mast cell activity, but there is still something driving that. There are still triggers that we have to take care of. So still the same conversation of, yes, you can actually go and at the very least, if somebody's suspected to have tethered cord syndrome, we should be exhausting mast cell support. And then even deeper than that, why their mast cells are angry. And that's working on the inflammatory loads, which can be stress reduction for some people. That's huge right now in this world, is just the amounts of stress that we undergo that releases corticotropin releasing hormone and aggravates mast cell activity. And like it's this cycle that leads to neural inflammation as well. So there's a lot of things that we could be working on, but the inflammatory load, why is somebody inflamed, will need to be worked on. And then I think that people do need neurological retraining, and that looks different for everybody. Sometimes that is just finding a safe space. We had this conversation about one of the patients that you've seen more often than I have recently, who felt like her shift in healthcare was when everybody finally agreed, we don't know what to do with you. We don't think there's anything to do. We think you're stuck like this. And it was the agreement, finally, of all of her providers saying the same thing, that she's now proving them wrong and she's improving, and they're using her as case studies. So it's just the idea of coherence between the medical providers and understanding the science and understanding the patient, and validating through science and explanation and education that can even help reduce that reactivity in the system. So even that can be neural reeducation, is the education
Sure.
in itself.
Because when we're thinking neural re-education, we're considering like vagal tone, like the capacity to shift between sympathetic and parasympathetic state. So it could be like something physical through the diaphragm, or something like passive through, a stim machine clipped to the ears. Like,
Yeah.
We should probably do a whole podcast on inflammation. If you are just getting into either investigating things for yourself or your provider, like, where's some good places to start thinking about inflammation, or any tips that we could give people? Because one of the things I notice is I'll talk to somebody and we're doing a little consultation, and I'm asking about previous tick exposures. Perhaps did you grow up in Missouri? Like, where are we at? Mold exposures, anything significant pop out? And sometimes people will have a hyper responsive, like, oh, I've done all that, like I've exhausted that, almost traumatically, where somebody's
for sure.
just hyper focused on the one thing, like it's got to be the mold, it has to be this.
It's not. It's the balance of all of the things in your giant petri dish of a body.
Okay.
It's a little bit of puppeteering. It's considering all of the things, and also, again, not just inflammation. That's so the recipe that as of today, sitting down with you, is what can we work on the body's inflammatory levels? And then what can we do for neurological retraining, which can be super passive or it can be very active. There's a world that, yes, we'll have a podcast on that at some point. And then honestly, finding the right manual person that knows how to work on neurovascular plumbing. And I am so sorry, I don't know a lot of people that do that. I know that there are like lymphatic work that focuses around spinal tissue can be helpful.
Like from a
Specific,
quality, like licensed massage therapist, like
a
some of that.
certified lymphatic
Okay.
therapist. Um, if we're talking about this neurological or the neurovascular plumbing, fascial counterstrain is where I've heard the language used. I haven't heard that anywhere else. I've heard it talked about by people that I work with in Baral, which there's some nice like neuromeningeal manipulation. That stuff is really good for cord tethering, feels good, but it's the plumbing, not just the nerve movement. It's the plumbing as well we have to free up. And I hear like Gail Wetzler, who teaches for them, she said that to me as she was working on a shared patient. And I was like, well, who teaches that? And she's like, it's just a Gail thing. And I'm so hopeful that people start coming out with these classes. And that's where please have patience with us as providers. Fascial counterstrain is evolving so quickly and so fast. It's very hard to keep up with the work, but it's new. This is new stuff that's coming out. The brain stuff within Baral, this is newer stuff that's coming out. It's hard to find a provider. I understand the struggle. I really, really do. We need more providers that are starting to train in this or finding other. I'm sure there are other classes that teach neurovascular clearing, but that's what we need. This lymphatic structure, these structures around the spinal tissue and the brain stem, all of it. This is all connected. We need all of that drain. So
Sure.
finish this is what we like to work on. It's inflammation. It's this neurological retraining. It's the manual work and finding somebody that knows how to work on neurovascular plumbing. It is working. I do like tools and modalities, which could be microcurrent is the most efficient, but you have to use it right in understanding this complexity of the dynamic connective tissue and environment model on the neurological tissue. So it's not just the adhesion of the dura. It's way more complex and complicated, but it can be used for that. So microcurrent, red light therapy, yes, vagal nerve stimulation, those sort of things as tools. I think having a tool is very helpful because this takes a long time to break out of. So pain relief is nice. And then what we have found is we talk a lot about this in to out training, like brain to body, of like calming it and convincing it it's safe. And but we have to do that from the peripheral nerves back in. Like an example that I hear a lot is people that we've put into remission from tethered cord symptoms trip and they go to catch themselves. And then within 24 hours, they have this flare up again. And that's because we have to reteach the nerves that it's okay, you can move. We're going to practice this over and over. So actually creating a neural retraining program with nerve glides, but considering reteaching the autonomic nervous system safety during the neuromobility. So that's like a you and me thing. And I heard there's some other people doing stuff like that too. But again, this is so new. A lot of this is so new, such new stuff. So I understand it's hard to find a provider, but that's the magic that we found in our clinic that works. And that magic typically takes 1 to 2 years to get to a stable baseline and reduce symptoms. It doesn't, and it can take longer than that. I mean, what if your major stress, neurological inflammatory load is the fact that, you can't move out of your house full of mold for 7 years because you can't afford it because you're in a health flare up.
This sounds personal.
This sounds very personal, doesn't it? And your story might be longer, but I think it's helpful in the validation of understanding why you still have those symptoms. So in my personal story, it's a little bit of a train wreck as to why I didn't consider surgery. Pretty much my symptoms were flaring during the pandemic when we didn't have health insurance because we didn't have money for health insurance. It was just so loaded as to why. And surgeries for me, I was terrified of because I had problems with anesthesia and neurological complications after every surgery. So I did not feel like my body was in a place where it could handle any sort of procedure, and I had no access to specialty providers. So that was my story, and like why I had to wait so long and why I now specialize in all the non-surgical strategies is because the pain is horrible. The pain is horrible and horrific, and it just doesn't go away. And that's why when I talk to people, I'm like, I hear you. If my timeline that I'm telling you does not match what you feel is something that you can get along with, we can have other conversations. But in regards to the tissue, releasing the phylum and doing something to the anatomy does not change everything else we just talked about.
All the interstitial mess,
All the
all the
interstitial
plumbing
mess.
issues,
And that's
all of
where
the inflammatory vagal, blah, blah, blah.
right. And I know there's talk about like shockwave therapy. That's, I mean, if you think about it, it's potentially reactivating lymphatic, those lymphatic pumps. So it's helping with the plumbing. It wouldn't be the first thing that I jump to by any means. But I know that a lot of people are talking about shockwave therapy for tethered cord. You're moving your plumbing, but are there better ways to do this? Possibly. Is it accessible for everybody? No. So having tools like that might be helpful. But yeah, it's a plumbing problem. We have to clear out the plumbing. We have to reduce the inflammation. We have to reset the nervous system. This is really difficult to do. That's why I wanted to get up here and say, like, this is really complicated. But I think starting to educate people on this is what you're dealing with. You're dealing with a complex layered issue that takes a lot to work out of, with or without surgery. Even with surgery, you usually have to do all of these things that we're talking about. So
is that where, correct me if not speaking the right words, but if we're not doing some of this background work and we're getting surgery and we're retethering, in your experience, is a lot of that retethering feeling, a lot of these processes just activating again after X amount of time or X amount of more stressors or
yes.
exposure to this or that?
And that's what, you know what, and I'm not saying I can cure anybody of tethered cord. I can't. I don't know if that's possible because I'm not changing your connective tissue. I'm not changing the way that your body responds to inflammation. So that's where I know somebody just told me the other day that somebody was arguing with them on one of the social media groups that you can't have a flare up of tethered cord. You can if you're in remission. So you absolutely can if you put yourself into remission. And that's where I want people to understand a lot of what we're talking about. I'm not going to change your connective tissue, but can we get you to a more stable baseline that your pain is under control? Not that it's going to be completely resolved, but under control. Your pain perception is improved. You're doing functional things. Like I'm at the point where I've almost got my lumbosacral area unlocked. I felt like a marionette for years, but I can run and I can jump and my legs feel free. And I'm not there yet. Like we can bring people into remission and they can still have a flare up because the inflammation levels increase again. Or anatomically something goes out again and they need that adjusted. So that's what, yes, you can have a flare up of tethered cord if we bring you into remission. And then do you have the tools set up? That's why I'm all about education. I want you to know more about your condition than I do, to be honest. Like that's what, when I talk to people who have, that we have gone through this process and they come back and I also want people to understand that when you are in a flare up, in that moment, it doesn't matter how educated you are going to feel like nothing worked. Your brain is going to tell you because it's neurological inflammation, right? And the brain does not have a whole lot of pain receptors. So when the brain and the neurological tissue becomes irritated, you go into desperation and despair and panic and anxiety because that's how your brain sends off the alarm bells. Something's wrong. It's not pain. So you have that when you're going through a neurological flare up telling you, oh, nothing has worked. I did all that work for nothing. Here we are again. I'm going to have to go back in. It doesn't matter how many times I don't tattoo it. Please don't tattoo it somewhere, but like write a sticky note to yourself, write a sticky note to yourself and put it somewhere so that when you have a flare up, you know, like even for me, I go into panic modes because I don't have great neurological tissue. I don't feel like I have like a psychological component or like I feel like I am a good person. My brain is healthy. My neurological tissue, not so much. Like that's faulty at times. And it brings me into this moment where I feel like, with all that I know, that, oh my gosh, I'm going to have to go call the CSF League Clinic. Weird. I was doing that in the spring because I had a migraine that lasted 8 days. Then I realized where it was coming from. So don't despair. Write yourself a sticky note, put it somewhere. Flare-ups are going to mentally throw you into the space of nothing's working again. And then write down your tools that work for you and then pull them back out. So it's really in hindsight, right? As we start to calm down from the flares, then we can start using our tools again. So not curing anybody of tethered cord, but remission is possible for so many people.
So then let's talk about this 11%, these humans that are a little bit more subjected to tethering issues due to genetics. You want to kind of wrap things up with a little bit of talk around that?
Yeah, like what question do you have?
Gene variants that predispose, like due to...
Oh my gosh, I don't know.
Well, we were just talking about just within the past couple of years how these layers, we're just figuring out what types, they're connective tissue, and you were starting to pair up.
Sure. We don't know. I mean, we need so many repeated studies on this because the extracellular matrix is dynamic in how it interacts and breaks down and builds up with its environment. So there was one study done on meningeal tissue that looked at the different layers and did find like collagen 2A1 was the main one, collagen 5A2, collagen 4A1, I think. But then there's this theory that collagen 11 also plays a role. I think that might be in that. So there's a lot. There's like 40 different proteins that they identified had a crossover between the brain and the spinal cord tissue. But that needs to be repeated over and over to validate that study to show us that this could be a problem. And like collagen type 4s, we currently don't consider, talked about this, I think, in our other podcast, they don't consider a connective tissue disorder yet. They consider it a kidney problem, but we're just talking about a different type of extracellular matrix in barrier systems. So actually layers of the skin, but also layers of organs and blood-brain barrier. I mean, I think those are important too.
Sure.
I don't know. So we really have to redefine how we're thinking of extracellular matrix components and understanding just where they're located. So I can't really have a conversation around that because we don't have enough research to support some of the stuff like collagen 9s. That's been coming up in the clinic recently. Collagen 9s are funky. We have some people with some collagen 9 variants of unknown significance, which is potentially correlated in some people with Stickler syndrome. But so is collagen 11. And we don't really know all the places that collagen 9 is in the body. That's why I'm saying, like, we don't know. So come back to that question, and then there's this whole idea of intron versus exons, and we'll throw this in here, and I think we'll probably talk about it maybe with a geneticist in the future.
Sure.
But I have people that have the genetic panels run themselves that are whole genome sequencing and in vitae, and the doctors that are running the in vitae are saying, no, nothing's on here. You have nothing, you're clear. And then they run the whole genome sequence and they find that they have something, that comes up on the whole
Sure.
genome. They take it back to their geneticist and their geneticist says, no, that's not a validated test. And depends on where you get it from. It is actually certified by the same companies that certify in vitae. So we called in vitae. We talked back and forth via email for a bit. And Invitae only tests exons because 80% of human disease is thought to be located on exons. Awesome. But we've kind of had this problem for a while that we can't find this whole HEDS thing. So what if we started looking at the introns? And a lot of people are popping up with intron variants. If you actually start looking at the research, you can have significant dysfunction with intron variants. There's just not as much research on it. So when you do those comparisons, understand that the variants that are popping up potentially on one and not the other could be intron variants that are not necessarily as strongly supported in the research, but nothing on HEDS currently is. So that's where, like, when we talk about
Sure.
genes and genetics, just tell me what your variant is. I want to know what that structure or function is. I want to explain what that does in your body so that you understand what might be happening or you're predisposed to or increased risk for, not to slap a label on. But
it does give you some leverage knowing, like, hey, I have this. I'm not going to escape this. I'm not going to change, just like you mentioned, not being able to change neurological tissue. Like that's something we can't snip out or alter.
Right. I think that we can prove inflammatory processes. I don't think that we can change. Well, we're just surrounded by so much inflammation that it's just hard to control our connective tissue's reactivity to those things. Yeah.
And leave it to our more sensitive, reactive population to pave the medical pathway, roadway, if you will, of like, hey, maybe you should be looking into these things in terms of genetics and just the different spaces to analyze.
So I mentioned it before when I was talking about something that if you look at the research in the connective tissue space, however, there's a ton of research out there on the extracellular matrix and other disease. And that's exactly what we're talking about in connective tissue disorders. We're just like, we're separating this language oddly. So there is research that's budding about chronic health conditions that are spurred from interstitial stasis in this interstitium, this, this organ of the body.
It's like you'll get to this point in the triangle either by talking about disease in here or like humans that have an issue with extracellular matrix dysfunction, and then they got to here.
Right.
And we just kind of live over here.
Right. We live over here in our own little bubble. But if we start to read the other research, extrapolate and understand what we're dealing with as a genetic predisposition, not as a label and a stamp, but just a genetic predisposition for a lot of these things, I think that, we'll understand how when we have, this combination of different collagen variants that can affect these different tissues. And then we have somebody that has these mast cell kallikrein or HAE components or autoimmune that make it difficult to respond appropriately with inflammation. Gosh, well, all of that. And then detox pathway genes, they don't have a good plumbing system set up. When you look at all that, you're like, oh my gosh, this person has a real tough time getting inflammation out of their system. And that's how I work with people. We look at your genetics and we create this story. And it's pretty benign treatment comparatively to other things out there, but it's just understanding like, gosh, well, this makes a lot of sense in your story, considering also we can look at like the neuroinflammatory markers that are in there, neurodegenerative markers that are in there that would explain why they have more likely, like a small fiber neuropathy response when their tissues become inflamed.
Okay. So kind of wrapping things up here, what if you just come across this podcast having been slapped with a diagnosis, or you just have some cord tethering symptoms?
Mm-hmm.
It sounds like, given the information that we've covered here, probably pick one of those lanes to go down to start to treat a little bit first, since it is a big, like a wide scope lens of there's a lot to do.
There's a lot to
Like,
do.
where should I start if I have symptoms right now? I have no diagnosis. Like, what's a good single place to start, or at least like framework for my brain?
Kind of the superficial stuff that we talk about with EDS, like, are our mast cells under control? Is the dysautonomia under control? I say that because that's not where I would start with somebody, but I feel like that's more accessible in our medical community now, is finding people who might be able to help you with mast cell or with dysautonomia, especially dysautonomia now. It still comes down to like specifically the inflammatory part of what virus, what this, what that. But like as the start.
Sure. In fairness to you, by the time people get to you, they've flushed all those things out generally with other providers.
Yeah. We still might talk about them.
Sure.
Because it just really depends. Like some people really do need a whole lot of mast cell support. Some don't. So it's really, it's unique to the presentation. But again, I caution going down the like neurosurgeon rabbit hole until you have good support from mast cell and dysautonomia components to be able to stabilize the system. It's kind of like a lot of things when inflammation happens to somebody with a connective tissue disorder, things get really foggy. It's really hard to see what the primary issues are. So when we work on the inflammation,
it's hard to see on yourself too.
Oh my gosh.
Like I think so much. Well, so much. I don't think I've helped you. We use voice a lot and we talk a lot of things out. I think so much of you, especially to my brain 7 years ago, was you need to say it so it can at least sounding board. Like, I think I did a
Right.
decent job as a sounding board. I wasn't like coming up with great ideas and treatment strategies, but a lot of times it was you need to have a conversation.
You need to have a conversation. And that's where, like, once you clear out some of the fog, it doesn't mean everything's like there's nothing there. The fog is gone and it's a smooth path. When you clear out the fog, that's when you can start to say, oh, it's this part of the spine. And then, okay, yes, it was that virus. And there are things to work on. But when you clear out the fog, the patient usually sees it too. And they're like, aha, these are my things I need to work on. They can usually tell you too.
Cool. All right.
Yeah.
Good for today.
Good for today. I'm sure we'll bring it up again at some point.
Yeah, sure. Thanks for sticking around with us. As always, if you have any questions or things you would like answered, topics discussed, please let us know. Send us an email or comment something below where this is posted.
Thank you.